okay? For those of you who do not know me, my name is Alia Galadari. I'm a consultant dermatologist in Dubai. And today is not going to be about me, although I'm the one who's standing and these two are sitting, the giants, right? What I'm going to do is I'm going to try and grill them through these 30 minutes, but it's going to be a very nice grilling, right? No, it's not really grilling, it's just, a casual talk. So we've got 3 cases that we need to talk about. And we're starting off with a café au lait macules, innocent pigmentation or neurofibromatosis type 1, right? So the question is, when you see, for example, a patient, let's say 3 years of age, no family history, these typical sort of macules and everything, I'm not going to talk about, for example, my patient. What I want to know is a bit of your clinical reasoning. So who do you want me to start with? You, Professor, or you? Anyone?
Whenever I see such cases in our OPD or in my practice, so café au lait macules is not very uncommon. I mean, we must know that the café au lait macules can be present in 5 to 10% of the normal children also. So couple of things we have to think. Immediately I look for the number of café au lait macules and the size of the café au lait macules. By below 12 years, the size should be 1.5 millimeter, above 5 centimeter, or above 12 years more than 1.5 centimeter, or even up to more than 5 centimeter. But number is very important, 6, not more than 6 maximum. And second thing, I look for the axillary freckling. So basically, I try to figure out whether this child is going to develop neurofibromatosis or not. That is the moot point. And I usually don't jump to investigations, because we know that all these features develop gradually over a period of time. In fact, most of the neurofibromas, they start developing from 10 to 12 years or even later. So there is no point in unnecessarily going for very aggressive investigations.
Okay, perfect.
And second thing is the counseling of the parents. Obviously, the parents are very much worried, and they read a lot nowadays on internet, and they need to be told very clearly that these are the things which we are keeping in mind. And by and large, in most of the cases, nothing to worry. It will be a simple café au lait macules, and it will remain like that, and later on it can be removed by laser also. Okay. So that should be the kind of approach.
So I'm going to pause a bit over here, and I'm going to ask you the question after I listen to Professor Ko. So go ahead, Professor Mark.
Can I just add to what Dr. Salipan said? So I agree, that the number of café au lait is important. And a lot of times we get referred patients with just 1 or 2 café au lait spots because the parents are very worried. After the last 15 years of practice, I realized one rule. If you had to count the number of café au laits to make the criteria, the patient likely doesn't have neurofibromatosis. So usually when I see an NF patient, once you take off the shirt, you can see all the café au laits. I know that's a criteria, but generally I came up with that rule. The other one is the freckling. That is also quite early. The rest of the features usually come up later. I think one important aspect is that I get a lot of referrals of other hyperpigmented conditions, querying neurofibromatosis, and a very common one is mastocytosis. So we get referred mastocytosis patients, to exclude NF. So you have to examine the patients very well. Of course, café au laits are very flat, whereas in mastocytosis or urticaria pigmentosa, it's usually a little bit raised, sometimes can be red as well. So, in Singapore, the parents are usually very, very anxious, and they come in having read a lot about café au laits and NF. So a lot of times they will ask, can I do the genetic test, right? So of course, you try to, if you don't think it is NF, I will try to deconvince them and say, no, there's no need. But if there is a suspicion and they're really anxious, sometimes I have to refer them to my genetics team to send off the test just to put them at ease. Just remember the leech nodules don't come out so early, so sending them for eye check is usually a little bit later. So if you send them at 1 year old, 2 years old, you may not see the leech nodules.
Forget about it, it's okay. I can whip it up.
And definitely I agree with Mark to a great extent. Dr. Mark, the way he has said, I actually didn't, mention specifically or mean so that you have to individually count. If there are multiple cafe au lait macules, you can immediately see. But if you can see just 2 or 3, as you have shown in this picture, then patient should be followed up, and number of cafe au lait macules are to be counted when it is countable.
Okay.
But many of the situations we see, as Dr. Mark says, the moment the child's shirt is open, we see multiple cafe au lait macules. So there is no need of counting the cafe au lait macules. This is number one. And number two, I also didn't mention about the least nodules, because many a times it is seen only in 20% case of full-blown neurofibromatosis. There is no point in unnecessarily hassling the parents. They'll go for an ophthalmologic checkup and least nodules. And many of the ophthalmologists, with due respect to them, they have never seen least nodules in their life. And you are sending to someone who has never seen. So what do you expect? That is the second practical things.
Okay.
And third thing is another very important thing. I have seen a couple of patients where, yes, cafe au lait macule is overlined by another small hyperpigmented macule, which is actually mastocytosis. I wish I could have shown that picture, but there was no time actually for interesting cases. It was cafe au lait macule, but in the cafe au lait macule, there was another more hyperpigmented, hyperchromatic type of macule, which on stroking produces Darier's disease. So
I'll be asking you a few questions, and then you just shoot me the answers, okay? So what is the typical age in which you see, for example, children who present with cafe au lait macules? So grosso modo, how old are they?
In Singapore, because parents are always very anxious,
Yes.
most times we see them quite early. Sometimes even, after, when they come for the 1 or 2 month check by the pediatrician, they will pick up 1 or 2. Parents go read, and they say, I want to see a dermatologist. So they end up with us. Of course, we have some that come to us only when they are in childhood. But nowadays, we are seeing more younger ones. So sometimes at that age, it's difficult to tell if the patient has NF or not.
So is it similar in India?
yeah, more or less similar, but not as early. We do not see, small kids having cafe au lait macules. By and large, in our institute and in my practice, which is basically pediatric dermatology practice, 80% cases, we see cases of cafe au lait macules, the parents who are bothered and come and showing us from more or less 3 to 5 years of age. This is the age group when we see, they are really bothered about cafe au lait macules.
Perfect. Okay. So
Can I just add one important point?
Go ahead.
The other thing that you can look out for, from a young age, are the plexiform neurofibromas. So if you see a lighter cafe au lait that doesn't have very clear borders, and especially if there's sometimes some hair over it. Do you have a photo of that? Do you have a photo of that?
I don't have the photo of that. You were talking about, for example, the regular, the typical, and the atypical sort of. No, I wanted to put that, but I didn't have the time. I was like, you guys were going to talk. So just tell them about these typical and atypical, because you were talking about counting the number of macules, but then you didn't tell me a bit, and you told me a bit about if it was segmental or non-segmental, right? And then you told me if it was associated with other sort of, let's say, symptoms, right? So you can, for example, think about certain, I don't know, rhizopathies, or you could think about other syndromes that are not necessarily NF1. But the question is, so you're talking about the typical ones, which is the coast of California, never been to California, or the coast of Maine, which is basically atypical. So would you mind elaborating a bit on that, Professor?
Yeah, I had in fact a difficulty in remembering during my MD, courses in PGI Chandigarh, a premier institute in India, how to remember coast of Maine and coast of California. So then I myself, found a key that in California there is a R. That means something which is irregular has to be California, coast of California. That is how I used to remember myself. So I shared that tip. But that does not really matter. These are all, very, fanciful description of it. Importance is that when the child starts developing other features from puberty onwards, particularly when the child develops neurofibroma lesions, the parents, they come even as early as I have seen 5 to 6 years of age. Some of the children, parents say, doctor, apart from these patches, which earlier, we consulted and we said, just relax. Just keep on observing. But we find something, hard nodules on the skin. And that makes them anxious. And that's bringing them to me, actually. So that means the child is developing neurofibroma lesions. And there we have to see how many neurofibromas, what is the extent of neurofibroma lesion. And that time the child needs and opinion from a pediatric neurologist. And I will never give an opinion regarding invasive investigations about the skeletal X-rays or CT brain or MRI brain or all these things unless and until I collaborate with a pediatric neurologist colleague of mine.
Okay.
And there is no history of seizures.
Yes.
Also the size of the café au lait macule. I have seen number of children, girls with large café au lait macule, huge café au lait macule. They are, you have to rule out whether there is PCOS, puberty or not, and we have to think about something very interesting syndrome,
Great. Professor?
Maybe I'll just add two more differentials of cases.
So I was going to jump into the differentials because you talked about mastocytosis. For example, okay, this is one of the differentials. People started talking about, for example, systemic lupus erythematosus as well, or they were talking about, for example, other unrelevant differentials. What are the differentials that you put mainly, the main ones, and how, I mean, it's a very loaded question what I'm asking you, but yeah, differentials.
So the other conditions that we get referred for these hyperpigmented spots from young, the other one is nevus spilus.
Yes.
So sometimes nevus spilus, they don't get the hyperpigmented lesion so early, it starts later.
Yes. So
they actually, but you can sometimes see one or two of these more hyperpigmented ones. So we get quite a lot of referrals for nevus spilus. The other one is segmental lentiginosis. So to tell the difference between café au lait and lentiginosis is that café au lait tends to be bigger. So if you see a bigger lesion like this, it's a café au lait. But sometimes in NF, you see small ones as well. But in segmental lentiginosis, you don't see the larger ones. You just see the small ones.
Right. Allow me just to recap just a bit of what we have talked about to skip to case number 2, because I realize talking to you guys is a never-ending, wonderful conversation. So I was going to ask all of these questions. What is your working diagnosis? What do you do now? And the criteria for diagnosis and everything, the differentials as well. And we do understand if you have café au lait sort of macules, it doesn't necessarily mean that you are fit for the NF1. Right. This is just a, for example, an algorithm that I really like. If you've got more than or equal to 6 café au laits, if it's typical or atypical, segmental or non-segmental, right? And if it's segmental and it's typical, yes, then it depends on the features. You consider sort of genetic testing, and I'll ask you about the genetic testing maybe later on. And then if it's no, again, you look at the clinical features and you consider genetic testings for azopathies. And then if it's atypical and it's segmental, then you consider again genetic sort of testing. And we're going to ask you about what sort of, okay, let's just pause over here after we're done with all of these. Let's forget about this algorithm. The question is, what sort of genetic testing do you do? Because we do have a number of ones, right? We have the exomes, and we have the sort of the whole genome sequencing, and we've got the next generational sequencing, and we've got even the targeted ones. So what do you start off with what test?
So for us, we usually send it for a resopathy panel. So it's a next generation sequencing, but it's a panel. They only look at the resopathy genes, which NF would be on there. Because sometimes we have had other genes that we picked up within the RAS pathway.
Yes.
Yeah.
Okay, perfect.
Yeah, I agree with Dr. Mark that it is a resopathy gene, for next generation sequencing, which is important. NFK1 gene also we see. We must remember that there is a condition which is known as Legius syndrome, where only it is café au lait macule, never the neurofibroma develop. And, there it is a different kind of gene, which is known as spread gene. So these are the things which you have to be kept in mind.
Exactly.
The other thing to add is also we've had patients whereby we've sent off the panel sequencing, it comes back negative, but clinically they do have NF as well. So sometimes you may miss, sometimes intronic lesions and all that. So unless you do a whole genome sequencing, then you can pick that up. So even if it's negative, doesn't mean that the patient, you can tell the patient you don't have NF. So,
I know the lady is going to get up and just going to say 4 minutes and everything, and she's crushing me on that. I'm a Virgo, so I really am passionate about timing and everything. So just let's finish with this case quickly and then go to the second case. So what we take from this is that clinical evaluation is paramount. The family tree and past medical history are important. In most cases, isolated café au lait macules have no pathological significance, and we do echo with you, Professor, that it does not require any investigation or follow-up. So there is no urgency to refer children of the generation general clinical examination is normal with normal psychomotor development and normal growth. And then specific difficulties in pediatrics as the absence of all diagnostic criteria must be interpreted in light of the child's age, and annual surveillance, particularly when cafe au lait macules are few in number and not associated with other signs because they do come with the years. Forget about that. Let's just meet. We have 3 minutes, right? 3 minutes talking about vascular birthmarks. Okay, no pressure. I'm not going to talk about his type of hemangioma in this art portrait, right? Let's just talk about when you see a kid who approaches you, or the parents. The parents are always anxious, right? And they come with their kid and they tell you, oh, doctor, I don't know what my kid has. Is it hemangioma? Is it a port wine stain? What do you do?
Yeah, basically you have to take the history that when this exactly this first appeared actually, and how does it appear? Did it appear, and how it is progressing? In case of a stork bite or nevus phlemeus, it will disappear over a period of time. It will gradually fade away. In case of true hemangioma, where there is growth of the capillaries, it will becoming a tumorous-like conditions, increase in size and growth. And in case of port wine stain, is a arteriovascular defect actually, capillary defect. So it will be at the present as and when it is present. It may not be always present since birth. It usually often comes later, but it will be dark stained, and it won't increase in size, in volume. It may increase in
So what happens if you're not sure, Professor? What happens? Do you tell the parents to come back in a week, in 2 weeks? What do you tell them?
They keep on coming back, but we have to reassure them actually.
Okay.
And we always take the history of any history of convulsions or not, and any other here the examination of the eye has got tremendous importance.
Okay, perfect.
Examination of the eye as well as examination of the organ system by a first pediatric neurologist, and if the neurologist feels, USG, abdomen and other things needs to be done.
Okay, perfect. Now, Professor, 1 minute and then we wrap it up.
Okay, maybe I'll just give some tips about this port wine stain and segmental hemangioma. So hemangiomas, especially the segmental one, sometimes at birth, you may be able to see some redness. Yeah, so I think that's important. It's not totally not present at birth. So that's the ones that can be confused with a port wine stain. So I do give them a follow-up early, maybe in a month, to see whether there's a growth of the lesion. The other good thing you can do is to ask them for photos. So nowadays parents take photos of their babies every day, few times a day. So you ask them for photos. So we've had cases that come in at about 2 months of age, right? And then it looked like a port wine stain, but there's a bit of ulceration. And then we ask them for photos, and they show us a photo at birth, and it was not there.
So quick question, because we've got 50 seconds, right? No rush over here. What do you do if it's, for example, port wine stain? Do you treat or do not treat? And if it was, for example, hemangioma, do you treat or don't treat? I know the answer, just tell them quick. You go, Professor, with the port wine stain, and you go for the hemangiomas. Perfect, let's go.
Yeah.
30 seconds.
In port wine stain, I just wait and observe, because it will be taken up later. In hemangioma, or there is growth of the capillaries, we treat with propranolol.
Okay, and what about you? Do you agree, disagree with him?
For hemangiomas, I guess it's really the site, the size, and whether there's any possibility of functional impairment. That's probably the first criteria. But if it's more functional impairment, if there's a chance. If not, then it's more cosmesis. So if it's a large one like this, then you know that it will proliferate. And a lot of times it's important that it will not totally go away. There is sequelae, especially the large ones. It can leave telangiectasias or atrophic skin. So you want to treat early. So I would say segmental hemangiomas, especially of the face, we will treat.
Okay, perfect.
Yeah.
You know what, professors? I thank you for your time. I think we're going to talk about all the segmental, all the red flags and everything on a side note, maybe after we take the photos and everything. So I think by that, this is a short panel. Maybe perhaps in the next sort of panel, we get to have more extensive time, Dr. Mohammed, huh? Maybe perhaps an hour. He agrees, he's nodding. Okay, perfect. Thank you very much for your time. And our time is up, no? لا ما هي واقفة كساوي الحين 5 دقايق 5 ثواني 5 هذا.
They all still want to stay.
So I don't know how much time do we have? You were just talking to us. And Georgina, Oh, Georgia, ما أدري نسيت اسمها. Georgia, huh? Really? And I was
Wow, we
rushing
went so fast.
them.
Maybe we should go back to the hemangioma. and
Okay,
talk a
let's
little
go
bit more.
back. Let's go back. Let's go back.
Yeah, let's talk a bit more about hemangioma. That's important.
خلاص؟ لا لا مو بخلاص. Okay, let's talk about the segmental sort of, we stopped about segmental, right? And we talked about segments. Tell me, why are segments important and why do we divide the face into segments?
So this was thought of quite a while ago already, and they have found that the more segments that are involved in a hemangioma, the more upper parts that are involved, the higher the risk of facies syndrome. So like in this kid, you can see that there's involvement of segment 1, 2, and maybe even 3. So the risk of facies in these patients is very high, and you really want to do the checks for the eye, the heart, the brain, and not only the brain, but the vessels in the brain. So we will send for MRA of the head and neck. We will send for 2D echo, cardiac evaluation, and evaluation by the pediatric ophthalmologist. So that's very, very important.
So Professor Sandapan, do you agree with him or not?
Yeah, I agree with him. And another important thing we have to remember, the more centrofacial involvement and more lower part involvement, the mandibular distribution, you see, you should try to rule out, you talked about facies syndrome, Sturge-Weber syndrome. So these two syndromes are very important as far as the hemangioma involving face of a child is concerned.
Okay.
And because they need early treatment, and early treatment to a great extent can give the child a lot of support as far as the comorbidity is concerned. Mm-hmm. And some of the hemangiomas, they won't go, with just oral propranolol therapy. They will need additional laser, like subglottic hemangioma, huge hemangioma, in the larynx, or hemangiomas in the organs. Many of the times they need a laser intervention, apart from the oral medication with propranolol mostly.
So, go ahead.
Just to add, if there's involvement of the beard area, you have to think of the airway involvement that Dr. Sandipan talked about. So if you see it on the segment 3.
Okay. So I do realize that investigations are important, and you said you send them for MRI if there are certain segments that were involved, right? And you mentioned a few segments, mainly one and...
If any of these, if it's a segmental hemangioma on the face and even the neck, there is a risk of facies. Of course, the higher the segments, the more segments, there's even a higher risk. We've had teenagers that come back to us because they missed the whole propranolol boat and now they're doing lasers. And I've done MRI at that stage, and you actually can see the posterior fossa abnormality at that age. And the only thing she couldn't do was ride a bicycle. Yeah.
Okay. So the question is, again, there's another question. كلها منكم ترى من كثر ما سرعتونا, and now we're going back because we skipped so many other slides. Let's say if the patient that I have in front of me has hemangioma, right? So what happens in, let's say, 80-90% of the time? Do you treat or you didn't treat? You said that you treat. Who said he treats?
I said.
You said you treat.
Yeah.
Okay, perfect. And if you treat them with beta blockers, right? And you treat them with propranolol, or do you treat them with local, for example, beta blockers?
Right.
So Professor, tell me, what is the objective, or what is sort of the treatment goal that you're hoping to achieve when you treat these kids early? Is it because it involves the face, as Professor Marco has mentioned, and that's why it is very necessary to intervene? Or is it something, let me know.
See, basically, this is a very important question you have asked. Important thing is that most of the hemangiomas, I would say 90%, more than 90% of the hemangiomas, they proliferate over a period of time. They don't remain stationary, and they involve larger areas, and they go deeper also. Okay. In maybe 10% or even less than that, some of the hemangiomas may spontaneously resolve, but that is only a matter of chance. So after observing for a few months, all hemangiomas need to be treated with beta blockers. The idea is we prevent the proliferation of the vessel wall. Number one. There are a lot of other complications associated with hemangioma proliferation. With that, you all know that what are the other complications. It has the tendency to invade inside, to to involve the liver, lung, kidney, and other organs. With oral propranolol, it has been seen it can be stalled and it can be very nicely treated. I agree with the Dr. Mark that it may not be totally going. Even after, we have treated many children with hemangioma involving the entire face, one half of the face. It is completely gone, but there are some telangiectatic spots. There are some residual skin, like a loose bag-like thing. Those needs to be later on tackled with plastic surgery. That can be nicely done. Blepharoplasty or all these things can be done, not a problem, or with laser. But treatment is very important, and early treatment is very important.
Okay, I'm going to ask you the question, but this is what he's saying is quite interesting. So let's say I treated a child with propranolol and everything is fine, just a bit of telangiectasia and a bit of that loose skin that ensues, right? And let's say the mother says, can you treat it with laser and take it off completely? So lasers are effective when it comes to the superficial part of that. And then when it comes to deeper ones, you're saying that plastic surgery needs to intervene. Okay. So lasers come after propranolol, right?
So there are some people that use lasers to treat the hemangiomas. And I've done that when some parents don't want to take systemic beta blockers. But I find that it's too painful. You have to do it multiple times. And I find propranolol effect is much better. Okay. But of course, if, let's say there is some residual, telangiectasias and all that, and some uneven skin, some parents may request for lasers, but most times the kid is very well. And because they've grown up with this, they are usually not too affected by it. So I usually tell parents, why don't you wait till the child asks for it? Because you know that it will still involute more over the next few years. So it can involute some more in the next, until they're about 7, 8, 9 years of age. Right? And at that point, they can then decide, okay, mom, I don't like this. I want to laser it. Then they will come and I'll laser it because the child has asked for it.
Okay.
Yeah.
So, now there's another part of that question. We're still focusing on the lasers, right? If you've got port wine stains and you've got hemangiomas, you treat early port wine stains or do you delay the treatment? And when is an ideal age to treat the children with port wine stains?
Okay, so most of the port wine stains come to us quite early because they're all picked up by the neonatologists, pediatricians, and parents in Singapore are very anxious, I always emphasize, and they come and see us. So I will usually start early. Why? Because I can avoid giving general anesthesia.
How early?
2 months.
2 months, okay.
From 2 months of age, I do it the recommendation is between 2 to 4 weeks, but because my clinic is quite busy, too many meetings, so usually I do it every 4 to 6 weeks. And I can try and squeeze at least 10 to 12 sessions before there is a need to consider giving general anesthesia.
So do you give them general anesthesia or do you give them local sort of, like some of them, they use a bit of sugar under the tongue, or what is your technique?
So I will only use general anesthesia when we are not able to hold the child, which is usually around about 1.5 to 2 years of age. Sometimes those on the limbs, we can hold them until, I've done it even when they're 3 or 4 years old, right? And I think even though there's no evidence for general anesthesia causing any brain issues, but personally I feel that multiple general anesthesias will somehow bring down their IQ. So I usually try to squeeze in as many as possible in the first 1.5 years without GA.
Okay, and the results are?
Yeah, and I would say 90% by the time they hit about 1.5 to 2 years, they're like, okay, we can stop.
Okay.
Yeah. The only one that we can't treat is the eyelid because you need to put the internal eye shield. So I can only do that with general anesthesia. So I do tell parents I can't shoot around the eyelids.
I know we can talk a lot about lasers and PDLs and fractional CO2s and everything, but then let's just not go into that, right? So if we'll just summarize this case in, let's say, 1 minute, and if we wanted to give these dermatologists over here, let's say, 5 practical points in which when they see any of a vascular birthmark, how do they behave? Like you've mentioned when it comes to cutaneous, the columns, right? Café au lait macules. So let's start with Professor Sandipan.
Yeah, I think 2 things I would like to mention here very specifically. That even if the parents in a case of hemangioma, not port wine stain, insist on, without any medical treatment, giving laser treatment, it is better for our sake to explain to the parents, look, this is a systemic process. The vasculature is growing from inside. We are just, by laser removing this thing, something which is visible. We do not know what is happening inside. We are not giving anything systemic or by oral, right? So there is a chance that after I do laser, you will find another lesion. Then that time you please don't come and say, doctor, after your laser, another thing has come. It is always better to clarify with the parents to be on the safe side. Okay. On the contrary, when we see and diagnose a port wine stain, it is better not to, waste propranolol unnecessarily in this child because propranolol is not going to work. So these two things are pole apart that needs to be clarified on the very first day actually of treating. And that is a very important part of patients or parents rather counseling.
Okay, perfect. I'll come back to you.
My tips?
Go ahead.
Yeah, so I think diagnosis is very important. So, you have to call a port wine stain and a hemangioma a hemangioma. A lot of people still call everything hemangiomas, all right? So if you have a port wine stain and give propranolol, it's not going to work. So you got to call it the right names and diagnose it properly. I think history, physical examination is very important. Sometimes time will tell. So even like cafe au lait, time will tell if more features of NF will come up. Same as for hemangiomas, time will tell, but don't wait too long, whether this is a hemangioma or a port wine stain. Discuss the management with the parents, because there are parents that I know, even a 10 centimeter hemangioma over the arm or over the chest, they said, oh, don't need to treat. Why? Because I had one when I was a child too, and I'm fine with it. So I've had that. So I think, number one, do no harm. Do no harm, right? And, but sometimes it's your judgment as well. In this child, if it grows some more, her eyelid's gonna, she's gonna lose her eyesight on the left side. So sometimes you may have to step in, and especially if it's a functional impairment. If it's a cosmetic indication, I usually leave it to the parents to decide. If it's a cosmetic indication, I leave it to the parents to decide if they want to treat. I will present the options and I let them decide. Because beauty is in the eyes of the beholder.
Mention, let's say, top 5 sites that you would treat the child with, let's say, propranolol if you see a hemangioma.
Yeah, number one is if it is present over the face, if it is present around the eyes, if it is present in the nasopharynx, right? If it is present, over the genitalia, where it is very likely to get ulcerated. If it is present in the perianal region. So these are the areas where it knows to get ulcerated.
What about the hand? Yes, no. What about the hand? So you talked about the genitals,
Yeah, of course.
And so everywhere?
Yeah, not everywhere, not the trunk.
Okay.
Right? Okay. Hands is also fingers. That means tendency of getting ulcerated is very important. Okay. Here I would like to mention another very important point. I have seen many a times the propranolol out of fear, many of our colleagues, those who do not practice pediatric dermatology, just dermatologists, they give a very small dose of propranolol. One should remember the propranolol does not work in a homeopathic dose actually. It has to be properly dosed.
So what's a typical dose?
You start with 1 milligram per kg of the body weight, divided into 2 or 3. Then gradually escalate the dose. You can go even up to 3 milligram per kg of the body weight. In fact, some of the people can have given up to 4 milligram per kg of the body weight. But unfortunately, I see many of the children, they are receiving 0.5 milligram of the per kg of the body weight dose for months together. And the parents say, then doctor, nothing is happening. Actually, the problem is not with the selection of the drug or the diagnosis. Problem is the dosing. So dosing has to be properly emphasized.
Okay. Do you agree?
I emphasize the dose needs to be at least between 2 to 3 milligrams per kilogram. Just a couple more tips. Those around the eyes, if sometimes you see it just on the eyelid, we have seen hemangiomas going behind the orbit. And in these patients, we've picked up faces syndrome as well. So even though on the face it's not so segmental, but they can hide behind the orbit. Another tip, as Dr. Sandipan said, there are certain areas that can ulcerate behind the ears, neck, axilla, groin. these can ulcerate early, within the first 2 to 3 months of life, and they ulcerate spontaneously. In these patients, we do give propranolol quite early. If it ulcerates, the other thing we do is we add on a short course, 3 to 4 weeks of oral prednisolone, and I find that it heals it up much faster than just with propranolol.
Would you mind repeating it again? If it ulcerates, then?
I will usually I'll start them on propranolol, and I give them a 3 to 4 week course of oral prednisolone.
I fully agree with Dr. Mark. He was just resonating with what I was going to share subsequently. When they ulcerate, and these are the areas, all the areas what he mentioned, the intertriginous areas, and the babies invariably they ulcerate after some time. Even I have seen babies who are on propranolol, and their propranolol does not work even if you escalate the dose of propranolol. I have done that, but I have seen no, the ulceration is not responding. Somehow they respond to oral steroid, and you can freely give it up to 3 to 4 weeks. After proper monitoring of growth, everything, all the parameters, and they show very good result, along with propranolol.
Perfect. So the last question is, how long do you put them on beta blockers, on propranolol?
The initial beta blockers, all the series, mostly they were carried out in Canada, actually. So all the large cohorts were from Canada when propranolol was started. And they have given at a stretch propranolol for even up to 3.5 years to even up to 4 years, right? So subsequently there were some issues were raised regarding propranolol induced, CNS changes and other things. Over a period of time it has been shown by and large you can continuously give it for 1.5 to even up to 2 years.
Usually because the hemangioma proliferates in the first year, usually by about a year or just over a year, you can probably start to tail. Yeah. That's what I find. But there's a small proportion that can recur again, and especially if it's at more sensitive sites, like over the eye.
And if it recurs again?
You can restart again. I would put them on another 6 months and then try to tail. And instead of stopping, I usually reduce the dose over some time. So that
how much do you reduce it?
So let's say the patient's on 2.5 milligrams twice a day, I can cut it down to once a day.
Okay.
Yeah, and then maybe every other day, or you can give them, reduce by a third or 2/3 and spread and reduce it over a few months. So I find that if it recurs, it won't recur so badly, and the parents will not panic.
Perfect.
Yeah.
Okay, I know you guys want to stop listening to us because they have the award ceremony coming up. I want to continue this conversation because it has been quite interesting for me. So ladies and gentlemen, give these two professors a big round of applause.
Thank you, everybody, and thank you
very much, Dr. Ali.
Thank you.
Give the moderator, Dr. Ali, a very big round of applause.
Thank you.